My belief is the single biggest problem in the US is not that we rely on employers to aggregate individuals into plans, but it's rather the extreme fragmentation of the US healthcare system. You can pick any single hospital on the West Coast, and if you could observe that operation, what you'd observe is that different departments have trouble sharing information with each other. They have trouble communicating. And by communicating, I mean they have trouble sharing relevant information at the appropriate time to maximize patient welfare. Now, that might seem crazy to people outside this industry. Like, what do you mean they don't communicate? There's computers everywhere and monitors, and there's always devices beeping and buzzing. Well, I'm sorry to report, no matter how many beeps you hear, health systems are not good at data management. They're not good at cross-department communication. That experience is indicative of what's going on in the entire healthcare system.
Welcome to Pacific Time, the podcast where we ask the big what-if questions about the future of the West Coast, its challenges, its opportunities, and the potential for independence. I'm your host, Greg Ammerfell. Today's topic is healthcare, which is in the headlines almost every day, and for good reason. Not only do every one of us in the U.S. interact with our healthcare system, it's a huge part of our economy and a source of endless hand-wringing. Healthcare reform was arguably the issue in national politics from the early 90s until the passage of Obamacare in 2010, followed by calls for Obamacare's repeal throughout Donald Trump's first presidential campaign in 2016. The federal government continues to play a massive role in ensuring American health through Medicare, its insurance program for seniors, as well as Medicaid, its program for people with low incomes. The feds also play a big role covering healthcare for military veterans and children. So here we are in the spring of 2025, and the second Trump administration and its proxies in DOGE, the so-called Department of Government Efficiency, are swinging their budget-cutting axes with reckless imprecision and wild disregard for the law, something I can comfortably say without political bias. Medicare, representing almost 14% of the total federal budget, may well be on the chopping block for Trump. While Medicare was long thought to be a sacred cow protected by elected officials from both parties around the country, sacred cows just aren't so safe from slaughter these days. So, not only is it a good time for us to consider the kind of healthcare system we'd like on the West Coast, it's imperative. And given the complexity of healthcare and how generally concerned we are on the West Coast about our individual and collective health, we'll be looking at this issue from many perspectives over time. What if the West Coast could draw lessons from the complex health system involving the federal government, state governments, employers, insurance companies, and oh yeah, us, the patients, so that we could design something better? Today, our guest is health economist and health startup founder, Mike Hanlon. Mike knows about the U.S. healthcare system in intricate detail. He also knows a lot about when and how big parts of our economy can be disrupted when the conditions are just right. Technology often plays a part. You see, Mike was employee number 7 at Amazon and has stories to tell about the early days of the e-commerce giant before it upended the way we shop. Mike left Amazon in 2001 and went on to earn his PhD in economics with a focus on health finance. He then joined the University of Washington's Institute for Health Metrics and Evaluation. It's a mouthful, so we'll shorten that to IHME, which is a renowned research group recognized as a world leader in health analytics. It's also a good time for me to note that after Mike worked there, I worked at IHME too. Mike has since applied his health economics expertise and technology chops as founder and CEO of Abett, a startup that's trying to get data flowing between key actors in the health system so that they can bring costs under control. Given his background, I was curious to hear Mike's big picture perspective. So I started by asking him about the state of U.S. healthcare.
I think it's fair to say that the U.S. healthcare industry is behind almost every other industry in our society at creating value for consumers. Now, compare healthcare to like consumer electronics. I think most of us would agree that healthcare is more important than the production of televisions. That said, if you focus on consumer electronics, it's amazing how much value that industry creates for consumers. The devices get better and cheaper every single year. In healthcare, too often, year over year, we pay more for solutions that are at best marginal improvements. You compound that poor performance year after year, and you have an industry that hasn't met the expectations or needs of our society. As a result, consumers are unhappy, and I think rightfully so. For the median U.S. household, real incomes have grown modestly in recent decades, even as companies have increased the amount of capital they put into compensation. What explains that gap? The extra compensation is going to pay for healthcare. Healthcare expense is the single biggest factor in explaining why real wages have been stuck.
So a grim picture. I mean, to go into some more of the things that we're hearing about, obviously healthcare is important. I saw a headline today that it's the single most important issue in the minds of voters, right up there with the cost of living. But we've seen a lot of headlines over the last few months. I'd love your take on this. I mean, one that brought you to mind was the murder of the United Healthcare CEO, and the subsequent celebration of the alleged perpetrator, which shined, I think, a bright light on consumer and patient dissatisfaction with the U.S. healthcare system. What's your take on what happened and how we got here?
Americans they clearly feel a lack of agency over their healthcare and their engagement with the healthcare system. My observations of human beings, and especially those of us raised in American culture, do not like it when we don't have agency. That condition makes us angry. Our relationship with the healthcare system is a problem that has developed over decades. It's fixable, but there is no single magic bullet to fix it. The fixes are going to require a lot of work. And hopefully it doesn't take as long to fix it as it did to break it. But the fixes won't be quick either.
Let's talk some more about those fixes in a little bit. Another rip from the headline question here. There's talk that the upcoming federal budget might represent significant cuts to Medicare. What would that mean for the healthcare system?
It is hard to fathom that healthcare systems across the country could continue to operate the way they do with that level of disruption of funding. Now, we could argue about the efficiency of systems and talk about marginal changes, but I don't know of anyone who could seriously argue we want to just disrupt healthcare, break it, and see what happens. Substantial cuts to Medicare would do that.
Research from our old employer, IHME, shines a light on disparities in U.S. healthcare by health, race, ethnicity, and gender at the county level, not to mention the level of expense at the county level. What do you think is going on?
Part of the challenge in the U.S. healthcare system is that there really isn't the U.S. healthcare system. And I think as we're likely to talk about later in the podcast, the extreme fragmentation of the facilities and physicians in our society causes problems. And one of the manifestations of that fragmentation is this incredible variation in outcomes and results.
Let's jump to that. I mean, I think it's well known at this point that the U.S. spends more on healthcare than any other country in the world, and yet has kind of middling outcomes. When you look at that macro issue, what do you see as the explanations?
Yeah, and I suppose just to give everyone the reference, there are a few conventional observations about the U.S. healthcare industry. The U.S. spends more on healthcare per capita than any other country. However, population health outcomes in the U.S. are generally bad. So we spend a lot, but the outcomes stink. In contrast to the U.S., other countries spend less and their population health outcomes are generally better. People also note that the U.S. has an employer-based healthcare system. That means most people in the U.S., north of 50%, are aggregated and served by an employer-sponsored health plan. In contrast, other countries use different mechanisms to manage healthcare administration. Now, the conventional explanation of that fact pattern is that the employer-based system is bad and other systems are good. And that leads people to argue that the U.S. should do something different, like adopt a single-payer government-run system. And when I was an academic at IHME, where we both worked, my job was to consider that question and try to find answers for that in a very serious way. Now, as an aside, I'm confident I had the best job in high academia. I traveled around the world to collect data to build economic models of health systems. And the goal is to understand how different types of health systems turned inputs into outcomes, where outcomes were measured as health service, population health. And in that role, I traveled more to in dozens of countries, literally, from Saudi Arabia to Yemen, Lebanon, Ghana, Kenya, Zambia, Uganda, Indonesia, Colombia, and also within the United States. And that experience led me to think carefully about the fundamental building blocks of a health system and how they differ across countries. So when I think about a health system, I'm not focusing on the political question of who pays. That's important, but ultimately that's a political question. I'm more focused on the fundamental building blocks to determine how does this economic activity occur? How do we organize those building blocks? And then how do we make the system function and work better? So with that context, really three reasons. I think first, when you're comparing different health systems, an immediate challenge is that different systems serve different populations. The average Norwegian is generally healthier than the average American. So it's not a huge surprise that Norway's health system can obtain better population health outcomes. They started that race with a head start. So now that said, economists will attempt to control for those differences in their analyses, and when they do, the conclusions largely remain the same. The US healthcare system is not great. Why is that? My belief is the single biggest problem in the US is not that we rely on employers to aggregate individuals into plans, but it's rather the extreme fragmentation of the US healthcare system. And in simple terms, we talk about the system as if it's a thing, if it existed. And the problem is it doesn't. So you can pick any single hospital on the West Coast. And if you could observe that operation, what you'd observe is that different departments have trouble sharing information with each other. They have trouble communicating. And by communicating, I mean they have trouble sharing relevant information at the appropriate time to maximize patient welfare. Now, that might seem crazy to people outside this industry. Like, what do you mean they don't communicate? There's computers everywhere and monitors, and there's always devices beeping and buzzing. Well, I'm sorry to report, no matter how many beeps you hear, health systems are not good at data management. They're not good at cross-department communication. And you often hear people complain about the experience of when you check in as a patient, you'd handed a clipboard and have to fill out the same information over and over again. That experience is indicative of what's going on in the entire healthcare system. The communication probably only gets worse as we zoom out from a single building, right? Communication across two different doctors' offices almost never happens in a systematic, reliable way, even though patients go to different doctors in different offices. Now, this fragmentation is a problem in Japan and the UK and everywhere else, but my observation and experience is it's a bigger problem in the US than it is in these other countries, and our system and our performance suffers because of this extreme fragmentation. And I guess there's a third reason too. Health systems have lots of constituents, right? There are patients, physicians, pharmaceutical companies, hospitals, the individuals and entities that pay for care, and so on. The challenge is you can't maximize the welfare of all these actors at the same time. You have to make political choices about who's going to win and who's going to lose, relatively speaking. Historically in the US, we've made political choices that favor a subset of those actors. And a combination of those choices with the fragmentation and our underlying population health means we see the crummy results compared to other countries.
So not to jump to the answers, Mike, but earlier you were saying, hey, there's a political choice to be made about who pays, whether it's the government or employers. But is there an opportunity for the U.S. to explore a happy medium? And have we indeed seen some examples around things like some centralized drug purchasing or other things?
Yeah, the U.S. system is, it's when I say that it's mostly an employer-based system, it's estimated now that about 54% of Americans are receiving healthcare through an employer-sponsored plan. So it's the majority, but it's a small majority. And it stands out in that no other country is close to that, or no other large country is close to that 54%. The federal government's a very large purchaser of consumer of healthcare. And by consumer, I mean, if you are setting the contractual terms that govern the activity and you're paying the bill, you're the consumer. So, Medicaid, Medicare are huge consumers of healthcare in the U.S. Collectively, employers are more, but not by that much.
Got it. Let me sidestep a little bit while we're kind of up in the clouds looking at the system. I mean, some would argue that the U.S. healthcare system emphasizes the system itself, insurers, hospitals, pharma companies, and practitioners over actually caring for the health of patients. Do you agree?
Yeah, the U.S. healthcare system prioritizes the interest of the quote-unquote system actors you define over the health of patients. It clearly does that. And in my opinion, no serious person who has studied this industry or worked in this industry could honestly argue otherwise. It just does. And we prioritize them to a margin that other countries do not. Let me give you one example of this point. Intermountain Health is a health system that operates in Idaho, Utah, and other parts of the mountain states. It recently published evidence that every physician devoted to non-fee-for-service primary care, so like a primary care doc where you just have maybe a subscription agreement. We have some arrangement where you see this doctor. So for every physician they devote to non-fee-for-service primary care, reduced hospitalizations by at least 22% and probably more. That same physician reduced ER visits by at least 11% and probably more. And in total, the reductions in hospital services from this one physician would reduce a hospital's revenue by at least $300,000 a year, and probably more. Now, it doesn't cost $300,000 a year to employ a marginal primary care physician who's engaged in a non-fee-for-service contract, right? So it's a good deal for healthcare consumers. It's less money in total. You avoid the trauma of extra hospitalizations and ER visits. This is a win-win. But there is an actor who doesn't win in this transaction. The hospital that lost $300,000 in revenue. Does that make sense?
It does.
And from the narrow perspective of a hospital, this is a horrific situation. They don't want this. They don't want non-fee-for-service primary care stealing their revenue. They do everything within their power to the detriment of the American consumer to make it difficult to have these arrangements at scale. We have architected a system that gives the system actors a lot of influence over how care is delivered and by who. And, no country in the world ignores the interests of system actors. It can't, right? No country in the world absolutely maximizes patient welfare to the exclusion of consideration of other constituents. I personally think that it's time for our society to make slightly different choices in this regard and with an eye on focusing on patient welfare, even if that means some industry actors lose, relatively speaking.
Given your travels around the country and around the world, Mike, do you find examples of places that are doing a better job putting the patient at the center of the health system?
Yeah, last week I had an early morning call with a representative of the UK's National Health Service in Lancashire County, which is home to about 1.5 million people in Northern England. This administrator was very focused on trying to figure out, how do I get the data necessary to make the system work for patients? Now, he wasn't inconsiderate of all the other constraints and factors and actors in this industry, but he was being driven by that fundamental question of how to make this work better for patients. My company is currently engaged in a project with some actors and operating across several southern U.S. states. They are asking the same question. We often work with employers who have benefits plan fiduciaries who ask that same questions. So it is happening in the U.S. and elsewhere, but on the margin, it doesn't happen as much in the U.S., right? Too much of our system is being governed by people who have other concerns.
You mentioned your company. I think now's a good time to pivot and talk about your work with Abett. Can you describe what you do and what was the insight that led you to this work?
Yeah, so we build data management tools. And the goal of this data platform is to bring together all types of healthcare and benefits data. You can think of it as sort of a platform for any and all kinds of healthcare data. Most of our clients are large employers who want to reduce this fragmentation that we've been speaking about. Now, why would large employers care about this problem? Well, in the U.S. healthcare system, the employers play the role of the healthcare consumer. Right? They set the contractual terms by which this economic activity occurs. They largely pay the bills. And so thus they have an interest in solving this problem to make the system work better so that they can function as a consumer and get better outcomes for the plan when they have a fiduciary responsibility. Why did I think this was a problem? The insights that gave rise to this company, they date back to 2017. And it was me in engagement with a large employer. I realized that employers didn't have access to this information that I just assumed they must have. And I thought to myself, this seems insane, right? Because without this information, how could an employer possibly function as a consumer of healthcare, which is what they are? So the second insight was, well, okay, there's this problem that exists. They don't have the data. And the conventional wisdom in the industry is they couldn't get it, that this data belonged to other actors, other system actors, so to speak. But I realized the employers could get it. And I realized there were mechanisms to force the system actors to hand this appropriate subsets of information over to consumers. Now, it's crucial that this data management includes appropriate information security and privacy controls, which our product gives to the employers. Yet with those protections, you want the consumer to have information so it can make certain choices, can make better choices for the people it represents. A venture capitalist who led one of our early financing rounds had this line describing his job. And he said, my job as an early stage venture capitalist is to find entrepreneurs who know something that's true about the world, but that nobody else knows is true yet. The thing that's true about Abett and the healthcare system is we understood that the employers could actually get the data. And if we built the tools to give them the ability to function properly, they would act in ways to change the way the healthcare system worked. So that's our thesis. That's why we exist.
So I think what you're saying by analogy is if you were a consumer who walked into a store or went onto Amazon or Etsy or some other retailer and you saw all the products you wanted, but there were absolutely no prices to be found and no one to explain them, that was the employer buying health insurance for their employees.
We have a client, is a large employer who I can't identify, but big employer, right? Everyone knows their name. And they describe an experience where before, go back 5 years ago, and they had shared bank accounts with the plan administrators, the insurance companies that managed their plan. And every single day, there would be somewhere between $10 and $15 million taken out of a shared account. Now, the corporate executives in charge of this could not tell you, why was it $12 million yesterday and $13 million today? Like, no idea. Like, are we getting fair value? Are people getting the appropriate service? Are we as a consumer acting like a consumer? And these are incredibly competent organizations and incredibly competent people. But if they don't have any data to answer those questions, their competence doesn't matter very much, right? When I first started in this industry, it's really easy when you're an outsider to criticize it and say, gosh, this just seems like a disaster over and over again. We're spending too much and getting poor outcomes. And I realized the analogy was, I'm actually from the state of Alaska. So I was in Alaska when I thought about this, and lots of general aviation, lots of planes. And I thought to myself, it's like you see the planes crashing over and over again, and you're tempted to criticize the pilots. And what you realize is the plane barely has any controls and zero instrumentation. So of course it crashes, right? Our job as a company is to give these professionals controls and instrumentation so they can manage this economic activity.
Got it. So you want to see more information flowing so that employers in particular can act like stronger consumers in their purchase of healthcare.
Yeah. And our belief is that the employers are the actor who can change the way the U.S. healthcare system works. So we're going to build tools for them and let them go to it.
I'm putting myself in the shoes of someone who's outside of this industry. I mean, I think all of us sort of experience healthcare. We probably all kind of roll our eyes at its complexity, at things that seem really, really strange. You've seen up close some things that were probably really wrong. Can you give some color to the sort of behaviors of the system that have been really terrible for people or for the employers buying health insurance?
Let me give you two stories. One employer has a large plan, and they have a concentration of retirees in one particular metro market. And we conducted an analysis to say, let's just look at people who are receiving dialysis treatment in this one specific market. And let's consider a counterfactual where they would go to the next most expensive dialysis center. So the people who went to the most expensive dialysis center, what if they went to the next most expensive one? And this was a relatively small number of people, I think 35 people in total. And the savings from that was about $17 million. Now, there's a reason they don't go to the second most. It's not as nice, whatever. And so, but right now there's no incentives. There's no system to properly motivate people to consider different choices. There's no market mechanism to convince the market leader that maybe it shouldn't be charging something like 5 times most expensive option. Those types of problems are rampant in the U.S. system. Another example is we've done analyses we're working with employers to identify MS patients and the treatment regimes they're on. It's pretty common. Very high fraction of MS patients are not seeing a neurologist who specializes in MS. Well, it turns out it's actually really easy to switch doctors to someone who does specialize in that condition. And we know there's all sorts of evidence suggesting you'll get higher efficacy treatments at much lower costs. There's just enormous inefficiencies in the U.S. system because there is nothing akin to a market mechanism to try to fix these things. And there are actors who profit handsomely from these inefficiencies.
Let's talk about another actor in the system. What role does the federal government play with regard to the health system?
The federal government is a huge financier of healthcare through Medicare and through its support of Medicaid. That's an important role, and it's pretty clear what they do there. My take on the federal government is based on my experience as an academic studying this. It's not the conventional wisdom. But what I realized as an academic is if you go back to around the year 2000, the federal government's share of healthcare expenditure in total peaked, and it's been decreasing ever since. And I think up until at least the second Trump administration, but through the Biden administration, I would characterize what I observed out of Health and Human Services was largely an area of mature bipartisan agreement. Republicans and Democrats had different takes on certain things, but health's really all I know. But for all I know, it was the last area of mature bipartisan agreement. But it largely was through, up until a few years ago or up until very recently. And what they had agreed on, regardless of campaign rhetoric, was they wanted to get the federal government out of the business of healthcare. And there have been attempts, again, the Republicans and Democrats have slightly different strategies of how they prefer to do this. But if I could summarize it really briefly, I'd say they wanted to kick the responsibility to the states. Now, the state governments realized what was happening here, and they didn't want to hold that bag. So they figured out that, they're passing rules and regulations, sort of kicking this down to employers. And employers, for various reasons, have been slower to kick this responsibility to specific individuals. You see that, but for the most part, employers have watched their healthcare costs go up. They've sort of tried to play that role. My observation has been this long-term trend towards making individuals more responsible and accountable for care, which is scary because we don't really have the systems to accomplish that in a sane way, right? But if you ask me in 30 years from now, do I think employers will still be the most important consumer in the U.S.? I don't. The trends don't support that. The feds are desperately trying to get out of this business, so to speak. Now, it's saying that you're moving the Titanic isn't even dramatic enough to make the point of what that's like, right? When I think about West Coast healthcare, I think in your first episode, you mentioned, I think it was a thought exercise, what would an amicable divorce look like? The real problem in the U.S. is healthcare systems are incredibly fragmented. It's not like we have to haggle over what it would look like to separate the health system. Rather, let's focus on what would it look like to actually have a West Coast health system. What would it look like to have a health system, a true health system in Washington State, for example, or California? Building that up, you can do that. You can do that regardless of the thesis of this podcast, and that's what I would argue we should try to aspire to do.
I mean, first of all, just to level set and take stock of the West Coast and its healthcare, is there anything that you observe about the West Coast and the way it provides healthcare that's different, better, the same, worse than anywhere else in the country?
Yeah, I think there's an important point about healthcare that's useful to understand. If you ask me, is the healthcare system in Washington State better than Mississippi? I would say yes. I think that's a factual answer, but it's a very misleading one, actually. And the reason is, we're talking about averages or these aggregated outcomes. We're ignoring all the variation that exists. So let me give you one example to highlight this. Historically, Virginia Mason in Seattle has been recognized as a great provider. It provided high quality service across conditions at low prices. If we examine Virginia Mason specifically, we just might conclude this is like there's great work going on as one of the best healthcare systems in America. That's awesome. But let's say you're talking about the city of Seattle and not just this one provider. Well, there are other providers in Seattle that don't meet that same bar. So if you say, what's the quote unquote health system performance in Seattle? It's like, man, it's okay, pretty good, right? But there's other facilities weighting that average down. Now we go to that aggregation at Washington State, and it's like, yeah, I guess it's kind of fine, but there's a lot of bad actors mixed in there. We could go through that same exercise for the state of Mississippi. I have no doubt there are providers in Jackson, Mississippi that are better than providers in Seattle or San Francisco or name your market. But on average, we're doing pretty well here for what that average is worth. Washington, Oregon, and California all have large, highly competent health systems aggregated in these dense metro areas. That's a recipe for success in this industry. Consider a state like Alabama or West Virginia. They have more rural populations. They have less healthy lifestyles. That's just generally not a recipe for success. So do I think the hospitals are quote unquote better in California or Washington or Oregon? Probably, maybe, but the real driver is they've got an easier problem to solve.
Got it. So what I hear you saying is the way we measure healthcare may look better for the West Coast, but that might be a reflection of factors other than the healthcare system itself.
Yeah, no, I think that's true. Now, again, if we got really specific and held everything constant, would I bet on the West Coast systems outperforming the rest of the country? I would, but that difference is probably pretty marginal.
Right. It sounds like you're saying there's not anything that the West Coast health system does particularly better or differently or worse than a health system in Mississippi or elsewhere in the country. And I think you're also saying the nature of the federal government's involvement in healthcare doesn't really have any clear effect, positive or negative, for West Coast healthcare.
Yeah, in a divorce, healthcare is not a margin in which the parties are going to be fighting.
So, Mike, from the perspective of the population, is the West Coast healthier than other parts of the country?
By almost any population health metric I've seen published, the population of the Coast is healthier than the U.S. average. On the West Coast, lifespans are longer, rates of cancer death per 1,000 individuals is lower, and so on. The evidence I've seen published suggests those outcomes are largely driven by lifestyle. For decades, smoking rates have been lower on the West Coast. Obesity rates are lower. Population's wealthier and more educated, which impacts the consumption of healthcare. By nearly every measure, the population on the West Coast lives a longer, healthier life.
So given that, if you were going to design a health system for the West Coast, what would be different in the system that you design around those characteristics versus a system that's dealing with a much tougher situation?
The fundamental problem I think you want to solve in any healthcare system is reduce the fragmentation. Make it so Department A can speak to Department B so that the data is traveling as fast as the patient. But on the margin, you have a population that requires less intensive services because they're generally healthier. Preventative services will have more of a positive effect, right? Because you're just much more likely to keep that, whatever the condition is, you're just more likely to prevent it from progressing to an acute state that requires these complicated machines in big buildings. So I think if you said, look, we're rolling out a non-fee-for-service preventative care, right, primary care across the country, that makes sense everywhere. It would have more of a positive impact with a healthier population, which is what you have on the West Coast.
I mean, Mike, if you could start from scratch on the West Coast and design a healthcare system that was optimized for this population of people and this set of capabilities, what would you sketch out?
As we've discussed, the West Coast has excellent building blocks, right? Some of the best individual departments and some of the best hospitals in the world are located in the states of Washington, Oregon, and California. The problem is the integration of those building blocks. Today the integration is poor, and to the degree it exists, it rewards quote unquote system actors versus focusing on patient welfare. I don't believe we need to start from scratch. The building blocks are awesome. To use a sports analogy, it's like we have awesome athletes on our football team, but they're coached really poorly and nobody's calling any plays, right? Imagine a football team that was like meeting in 3 different huddles and the quarterback wasn't allowed to speak, right? It would be a disaster. That's the healthcare system today, right? We don't need better players. We need coordination, and we need to think of them as building blocks and think about how they're integrated and make sure that when somebody has MS, for example, they are directed. There is some market mechanism to direct them to someone who actually is specializing in that care at an appropriate volume to ensure quality. When somebody's making a choice that imposes maybe $1 million in annual expense for, dialysis treatment, there's some market mechanism to correct that. And the first step in that market mechanism is just making sure information's flowing to all the different actors.
I think you're making the point really well that information flow and integration are going to be vital features of any new health system anywhere that we could dream up. But you've mentioned some other things that I wonder about. If we were starting over to design any health system for the US or for California or for the West Coast, would we recreate the employer role? Would we imagine a role like we see in Canada or the UK with kind of a national government single payer? What would you do if you could start from scratch?
That's a question in which people have really strong opinions. Most people have strong opinions. I actually don't. I've seen the employer model work. I've seen, I think there's examples of single payer systems that work. There's no panacea here, right? They solve some problems. They all impose some costs. The identity of the administrator, the person who basically says, I'm going to take responsibility for aggregating people and coordinating the economic relationships and paying the bills. That's just not very interesting to me. So I live in the employer world. I see the benefits of it. I think that's not the problem, right? The employer system works fine, I think. Just shifting from the employer model to a single payer, keeping everything else about our system constant, I think we would have all the same problems, more or less, right? I mean, on the margin, they would shift. So I'm maybe one of the few people who just doesn't have a strong opinion about it. To me, it's a political question, and we can all make up our minds about that.
Earlier, I think you hinted at trying to build more consumer type behavior into the health system. What would be the best approach for the West Coast to do that? Is it about making patients themselves better consumers of healthcare? Is it about making employers better consumers of healthcare or governments better consumers of healthcare? All of the above?
It is all of the above. In the short run, you have to focus on who's currently the consumer. Again, we could argue about whether patients should be the consumer, how to aggregate patients. That's a complicated question. But right now it is employers and governmental agencies. And my experience of working with those constituencies, they have professionals there who are ready, capable of doing those jobs. But we have people who are flying planes with limited controls and no instrumentation, and that's not a recipe for success. What I think we need to do, and in part why I started the company I did and what it does, is to try to in part solve that problem, or in partnership with others solve that problem. Because I think if we give, whether it's, back to my friend in the UK and Lancaster County, or somebody, running Medicare for a southern state, Medicaid for a southern state, they are, or an employer, they are basically asking the same questions. How do I structure these arrangements to get better outcomes at lower costs? That's a both noble and realistic goal, because there's enormous waste in the healthcare system and poor outcomes. So a smart person with the right tools will get better results. We just got to give them those tools. And a big part of that is data.
Mike, you've spent an early part of your career as one of the first 10 employees at Amazon, a company which we can safely say has been disruptive in really interesting ways to the economy. What lessons about disruption do you draw as you think about remaking a system as big and complex as healthcare?
So you're asking what lessons did I learn in Amazon
Sure.
that apply to healthcare?
Yeah.
Nothing. I learned nothing at Amazon.com, unfortunately. And now that may not have been the answer you expected, but it's absolutely true. And I guess I should explain why. As you know, I was the 7th employee at Amazon.com. I was there in 95 through 2001. And during that time, there was a tsunami of demand, right? People were coming online for the first time, and Amazon was, for many people, the first thing they did on the internet was go and buy a book. From 95 through 97 or so, we grew 30% a month every single month, right? It compounds to be like 2,500% growth or something. It slowed down a little bit as we went towards 2000, but not by all that much. The challenge in Amazon was figuring out how to keep up. How do we grow a system to capitalize on the fact that this monster behavior change had happened? But one thing we didn't have to worry about is what's known as go-to-market, or focusing on people's behavior. The market came to us. We didn't think about it at all. And the challenge in the U.S. healthcare industry is we have to change behavior. We often think about go-to-market as synonymous with sales. It is sales, but it's more than that. It's about changing people's behavior, thinking about market activity differently. Healthcare is all about go-to-market, because ultimately we have to convince individuals that it is in their interest to change the way they are behaving. Not only individual patients, but vice presidents of benefits at large employers, executives at plan administrators, and so on.
Got it.
So I don't know, in retrospect, maybe I should have wrapped up my entrepreneurial career after Amazon and just called it a success. But I decided to dive into the deep end of a very different pool.
If you could have waved a magic wand, if there's one wish you could have had fulfilled at Amazon's early days to help manage the growth and the tsunami of demand that you saw, what would you have asked for?
Sometimes we fell into the trap of being too clever for our own good. And I remember, I don't know if this was 96 or 97, there was a meeting of the engineers and we were talking about how to deal with this rapid growth. And there was one curmudgeonly guy on the team who said, I don't know. And we were all sort of thinking about how do we, refactor the code? What are all the things we could do? Like, how can we show how smart we are to solve this problem? And the curmudgeonly guy said, I don't know, maybe we should just buy some more servers and just, throw servers at it. And it turned out that worked. And I think what I learned from that experience, and experiences like that, was it's easy to overthink things. It's easy to overcomplicate things. And there is value in being able to cut to the chase and say, what is the real constraint we were trying to solve here? We take, in my company today, we take that approach to healthcare as best we can. It's a completely different dynamic because we're not talking about adding a server. We're talking about changing behavior. But the goal is to get to the core root of it and not make things more complicated than necessary, which, a lot of people in the tech industry are somewhat wired to do.
All right, so let's wrap with a related question about healthcare on the West Coast. On one hand, what would you wish for if you could wave that magic wand for healthcare here? And on the other hand, what's the simple step that the West Coast could take to improve its healthcare?
Yeah, we have amazing building blocks, and we need to aggregate what we've got. We've got to connect disparate providers, administrators, consumers into a truly integrated network. Right now, when we talk about the healthcare system, we're talking about it in an abstract, conceptual way because it is an abstract concept. We need to empower communications between different parts of the system so that when you check in, you're not handed a clipboard to fill out your address yet again, right? That's actually a very simple and trivial problem compared to the other information flows that are blocked that we need to unleash. But if we do that, and we do that with an eye to thinking about let's prioritize doing this in ways that improve patient welfare and deprioritize the interests of system actors, I think we would have a healthcare system on the West Coast that really was a true existing system and performed much better than the one we have today.
Mike, any questions I didn't ask that you think I should have pertaining to West Coast healthcare?
No, but I love the idea of the Pac-12 getting back together. So that seems on brand for this podcast, right?
We will take up sports another time. Yes. Listening to Mike Hanlon, we get a very clear picture of the U.S. healthcare system, unclouded by politics or judgment. I have a bunch of takeaways about what this means for the future of healthcare on the West Coast. Addressing the healthcare system's fragmentation and tying together its information flows is a long, hard path to reducing costs and improving outcomes for us patients. And because of this fragmentation and the long, hard path to improvement, it's doubtful, according to Mike, that ownership of the healthcare system would be hotly contested between the West Coast and the U.S. My read is that integrating healthcare will be hard, but we can shrink the problem by going after it at the regional level, working at it together on the West Coast. Maybe that's something the efficiency experts at DOGE could endorse. While we're at it, working regionally would sure make it easier for the West Coast to define the rights everyone living here would have to healthcare. We could also protect health freedoms we'd want in our system. I'm talking about bodily autonomy for women, as well as for trans people. Two groups whose health choices and personhood just aren't safe under the current administration. Another takeaway for me was in Mike's insights about different healthcare systems around the world. Since the debate over Obamacare, and maybe all the way back to Howard Dean in the early 90s, liberals have fantasized about a single-payer healthcare system like the ones in UK and Canada that have government paying and guaranteeing basic care to every citizen. While it's true that systems like these may do more to put patients at the center of the system, these systems have challenges too. Were the West Coast to stick with the same kind of hybrid system we have across the U.S., with government and employers paying, there are ways to make that work better at lower cost. In both cases, it may come down to promoting information flows so whoever is paying, government or employer, can advocate for the best care and the best prices. Mike also highlighted that the population of the West Coast is healthier than other parts of the country, suggesting that a significant part of the taxes we export to the rest of the U.S. comes in paying for healthcare we don't need ourselves. So, if the federal government is shying away from healthcare by dramatically reducing what it spends on Medicare, the West Coast, with its strong healthcare system, its healthy population, and its ready access to the world's best information technology, has really big advantages at delivering healthcare that could be envied by the world. That's it for our first of many dives into healthcare. It was fun chatting with Mike. If sketching out the West Coast agenda seems fun, maybe even hopeful compared to the dreary national backdrop, make sure to follow Pacific Time on Apple Podcasts, Spotify, or wherever you listen. New episodes are going to keep coming Wednesdays at 6 a.m. Pacific Time, of course, nice and early for your morning walk, surf, bike ride, or commute. Please share Pacific Time with your friends, family, and neighbors on the West Coast. What would be the perfect kind of healthcare for you and for each of them? Talk it over with an open mind and share your views and questions online. We're at Pacific Time Podcast on Instagram, Facebook, Blue Sky, and the digital home we're building on Substack. This is Greg Ammerfell. Thank you for being with me in Pacific Time, and keep asking, what if, about the future of the West Coast.